Welcome to the Seasoned Sonographer, the podcast where experience meets education in the world of OBGYN ultrasound. My name is Lynn Flamm, and I'll be your host. I'm a registered diagnostic medical sonographer with over 32 years of experience, most of that time in OBGYN ultrasound. Through this podcast, I'm here to share insights, tips, and case studies to help you sharpen your skills and optimize your scans. Whether you're just starting out or you're a seasoned pro, this is the place to grow your knowledge and confidence. Let's dive into today's episode. Before we begin today's episode, I'd like to recognize our education supporters, Sono, Southern Illinois Healthcare, and Rachel Health. These businesses are committed to advancing OBGYN ultrasound education and supporting the sonographers and providers who care for women and babies every day. Their support helps make conversations like this possible and continues the mission of improving ultrasound knowledge and patient care. Thank you to Sono and Southern Illinois Healthcare and Rachel Health for supporting OBGYN ultrasound education and the Seasoned Sonographer Podcast. Welcome back to the Seasoned Sonographer. I'm your host, Lynn Flamm, registered diagnostic medical sonographer and founder of Sono Techniques Academy. Today we're talking about something that we see every day as sonographers, but sometimes don't fully realize the impact of: how ultrasound findings can change the timing and plan for delivery. Because what we document doesn't just stay on the screen, it drives real clinical decisions. As sonographers, there are certain findings that immediately shift a pregnancy from routine to closer monitoring or even early delivery planning. We're looking at things like fetal growth restriction, abnormal umbilical artery Dopplers, oligohydramnios or polyhydramnios, placental abnormalities like previa or accreta, abnormal biophysical profile scores of 6 or less, fetal presentation. And in many cases, it's not just one finding, it's how they all come together. We're also adjusting how we scan based on co-morbidities like gestational diabetes or pregestational diabetes, chronic hypertension or preeclampsia, IVF pregnancies, multiple gestations, and aneuploidy concerns or structural abnormalities. So we're not just performing a scan, we're tailoring our evaluation based on the patient's clinical picture. And what's really important is these findings don't just describe the pregnancy. They help determine what happens next. So now that we've talked about what we're seeing from the sonographer's perspective, I want to bring in the clinical side of this because this is where those findings turn into real decisions. Joining me today is Rachel Wernsman, a certified nurse midwife. Rachel, welcome to the podcast.
Thank you.
So let's start out with a little bio about yourself. Can you tell us your educational journey and how you became a certified nurse midwife?
Yes. So I originally went to nursing school and got my associates at a junior college by where I lived. And then I got my bachelor's online. And during that time, I was working as an OB nurse. And I worked as an OB nurse from 2014 to 2019. During that time, I went back to midwifery school. I actually did not know what a midwife was until I worked as an OB nurse. And so I went to Frontier while working as an OB nurse, and I have been a midwife now since 2019.
My goodness, that's awesome. So can you tell us about your role as a certified nurse midwife and how ultrasound findings influence your delivery timing?
So as midwives, I feel like we are still managing or co-managing a lot of high-risk situations because there's not an overabundance of doctors. So we use ultrasound findings to kind of give us ideas on different things to kind of give us some guidance. So in our world, I would say ultrasound findings are pretty important when we're worried about delivery timing in situations where babies may be measuring on the smaller side, or fetal growth restriction where we've got like a less than a 10 percentile growth, or the abdominal circumference is small. And then also in those situations, we're doing Doppler studies, or the ultrasound is doing the Doppler studies. Other situations where we would use ultrasound would be if someone has lower amniotic fluid, or antenatal testing in general would be for advanced maternal age, obesity, high blood pressure, whether it be pre-existing or gestational hypertension, gestational diabetes, if they're requiring insulin, or cholestasis would be probably the initial ones. And then if someone has late prenatal care towards the end of pregnancy, sometimes we'll add it on for those things as well. And then there's obviously a lot of other things that potentially would require it.
So those are some of the most common influencers that are affecting delivery timing in OB.
Yep.
When fetal growth restriction is diagnosed, how do you decide between continued monitoring or delivery?
So depending on how early it's diagnosed, if it is diagnosed earlier than 32 weeks, we actually send a maternal fetal medicine referral since it's so early. And MFM will offer an amniocentesis just to kind of dig a little bit deeper to see if there's, deeper things going on with that. Later in pregnancy, there's different categories. So severe fetal growth restriction is if we're at or less than the third percentile. And then regular or standard fetal growth restriction is between the third and the 10th percentile. So generally speaking, if they're third to 10th and they do not have elevated Dopplers and their amniotic fluid looks good, usually we're doing somewhere 38 to 39 weeks. But if they are less than third percentile or they're having elevated Dopplers, the standard is 37 and 0. And then if you start getting into the absent flow, inflow, reverse flow Dopplers, which are the more scary situations, they don't happen as often. Sometimes you're delivering as early as like 30, 33, 34 weeks in those situations.
My next question is, how important are the umbilical artery Dopplers in your decision making? And it just depends on if you have the absent flow, the reverse flow. Can you elaborate on that just a little bit more?
I would say they're very important. I usually explain it to people as it's pretty much the blood flow from placenta to baby. So if you've got a water hose that's getting kinked off and then you're not getting the flow and then things start reversing back, then you're not getting anything to the baby side. So, I mean, it could play a huge role considering if it's reverse or absent, you could be delivering as early as 30 weeks versus if you had a 9 percentile baby with normal Dopplers, you could go all the way to 39 weeks. So, I mean, it could give a huge couple month range on those Dopplers, deciding specifically just the Dopplers on when delivery would happen.
And again, I'm just sitting here thinking it's those umbilical arteries that carry the deoxygenated blood back to the placenta to be oxygenated. And in severe or even moderate placental insufficiency or resistance, that blood has a hard time getting through that placenta. And then that can affect those Dopplers by showing absent or reverse diastolic flow.
They actually, I had looked, it showed that the rate of perinatal death is reduced by as much as 29% with adding Dopplers on for antenatal testing just by itself. So I feel like that's pretty high to.
Yes, that is you must do those when you have a growth restricted baby to monitor that oxygenation. What role does the biophysical profile play in the late pregnancy?
At the beginning of this, when we were talking about the different reasons we would do antenatal testing, typically that is either the biophysical profile and a non-stress test on the same day or separate days. But the biophysical profile or BPP is used for monitoring different pregnancy conditions, pre-existing comorbidities. I've seen it mostly maybe catch a low AFI when checking for that, or potentially like non-reassuring baby. We've got a mom that is gestational diabetic, says baby's maybe not been moving quite as much and their NSD looks a little not reassuring. And then we get the ultrasound that may show that, baby's not moving or there's not good muscle tone. And in those situations, sometimes results in going towards delivery.
And then what about abnormal amniotic fluid levels affecting management, like oligohydramnios, less than a 2 centimeter pocket, and polyhydramnios, greater than an 8 centimeter maximum vertical pocket? How do those levels affect the management?
So for oligo, it is dependent on how many weeks you are. So if you get the diagnosis of oligo, so you've got the AFI less than 5 or the MVP less than 2, ACOG actually recommends delivery as soon as 36 weeks. So if you're any time past that 36-week mark, they're going to recommend delivery. We actually had a case last week and we called MFM and they said there's no reason to, IV hydrate, watch tomorrow, you go ahead and deliver. Poly, I don't have as much where we go towards delivery with that, but it is a good thing to know, obviously going into a delivery or going into an induction if someone's got a bunch of fluid. you're going to be a little bit more hesitant on breaking water. You want to make sure that the head is nice and well applied and that it's a head and thing, baby's not moving around in different positions. Antenatal testing doesn't actually get recommended unless it is severe, moderate to severe. So they've got it on the ACOG list as MVP more than 12 or AFI more than 30 is when they recommend adding the antenatal testing on there.
Okay. And then you talked about if there's too much fluid, baby's position can change. How does that change in position, or what other things change how a baby is delivered rather than when?
I would say the most common thing that would change the route would breech is one of the most common ones. So if that is found coincidentally or is found earlier in pregnancy and we keep an eye on it, we typically can offer a version where they will try to flip the baby in a hospital setting, or at our facility, we do not typically offer vaginal breech delivery. So it would be more of a scheduled C-section, or if you came in labor, we would do a C-section if it was found. Other situations that would potentially change the route would be if it's fetal growth restriction and baby does not look reassuring, then it's, you're not going to push it to the limits probably as much as you would with someone else. But just because a baby is small does not mean that you would have to deliver C-section. So it just kind of depends on what the fetal tracing looked like at the hospital. And then like say an abruption was found on ultrasound. If it's a chronic abruption or baby, again, is looking pretty well in the monitor, we're not having a bunch of vaginal bleeding, we will continue to try for vaginal birth and just be very cautious about what we're doing. Potentially with Dopplers, I would say if you have absent or reverse flow, and baby looked excellent on the monitor, you could consider trivaginal, but I think it would be a very long counseling session on what your labor may look like, and baby may not even tolerate labor. So I feel like most people end up opting probably for a section in that situation, but it's not an automatic.
So it's just having all the pieces of the puzzle, talking to the patient, coming up with a delivery plan on whether to do the C-section or a vaginal delivery. What findings typically trigger a referral to maternal fetal medicine?
Fetal growth restriction less than 32 weeks. If we have someone that we're having difficulty getting a full anatomy on, so say someone maybe is more obese than someone else, or a baby's not cooperating. Typically, if we've had a couple repeats where we're not getting complete imaging of the heart or something like that, we'll usually refer to them, or any like significant abnormal findings where we're worried about something maybe genetic going on. And you've found multiple things on ultrasound, we'll usually refer to them because they can offer additional genetic testing, amniocentesis, counseling, and things like that. I think a lot of people think, for instance, even if you have someone say their genetic testing came back and baby's positive for Down syndrome, I have a lot of people that initially will say, like, my genetic testing doesn't matter, I wouldn't do anything different. So we like to counsel on, we're not referring to have you have a conversation on terminating the pregnancy. That may be something that's discussed, but more of a giving you the resources ahead of time. A Down's baby may have different complications after delivery, so they can give you more resources while pregnant on what to expect, what kind of outpatient treatment you're going to have afterwards, or what the baby's life is going to look like. So it's more of a educational thing, not a pushing you to get something done.
From your perspective, how important is the sonographer's role? And we're, in a rural area especially, we're doing general OB second trimester anatomy scans, and there are sonographers out there that are still trying to, perfect their anatomy scan and still trying to be better every day at their anatomy scan. Thank goodness for maternal fetal medicine referral capabilities. And sometimes that is hard if the patient has to travel a long way and they don't have the resources. But how important is the sonographer's role in assisting all these things that need to happen?
Well, not to put pressure on them, but in most settings, it's pretty important. Midwifery school or my school, most schools do not offer any type of ultrasound training. So some places are doing, home births, so they're getting an initial scan or sending people out to different hospitals. Personally, I can check a heart rate, basic things, but the ultrasonographers, you guys are giving me the info that I need. I don't know how to check amniotic fluid, things like that. So it is very important on making the decisions, but hand in hand that goes with, if there's things that look abnormal or you're not for sure, a maternal fetal medicine referral isn't a fail in ultrasonographer's case either. I mean, sometimes it's just the way the baby's laying, but if you see something weird, 9 times out of 10, a patient prefers that referral to get the second opinion, to get the peace of mind, than to say, well, we don't really know what we're looking at. We'll look at it next time. Most people want you to err on the side of caution and would rather you be honest. So it is very important, but people are human and you can't see everything every single time either. So
you don't want to delay diagnosis. And a lot of times, if I'm not sure as a general OB sonographer, I'll just say, let's let somebody else take a look. They may think everything looks normal, but, they can also confirm that maybe my concerns are real and then, give you better resources. I like that MFM fallback that we have. So how do you counsel patients when their delivery timing or plan changes from what they expected?
I try to explain, I think the biggest misconception probably with fetal growth restriction is most people always say, if my baby's small, why do you want it to come out? Why can't it stay in to grow? So that's where you kind of got to get basic and explain that, plus there are placental issues. And in this situation, off of what information we have, baby statistically is found to be safer out of the body than in the body because of the way that the placenta is feeding the baby. So I think making sure that they understand versus just saying your baby's small, we want it out. Common sense, it would be a person that would think, well, why can't we let it, stay in there to grow? Can I eat some more? Breaking things down basic like that. Explaining that they still can have a low intervention birth. So even if you are getting induced, you could do a Cook catheter induction that, maybe doesn't have any medicine. Or if you're already dilated, sometimes we just break water, nipple stimulation, things like that. So I think the biggest thing is if their delivery timing is different from what they expected, see what they were wanting their labor to look like so that you can try to match that as much as you can, or kind of meet in the middle and tell them why you're recommending what you're recommending. But make their wishes valid. And then I think using statistics and also always still giving the patient the choice. I mean, you can't make anyone do anything. So I think if you end a conversation with someone who's very hesitant and say, ultimately, it's still up to you, that makes them feel a little bit more validated and listened to versus I'm making you go do this or you're going to go do X, Y, and Z.
Right.
It doesn't usually go across well that way.
It's that collaboration between the provider and the patient and a shared decision-making based on risks and benefits. How does the collaboration between sonographers, midwives, and physicians improve outcomes?
I would say it definitely probably helps with teaching if everyone's kind of on the same page, but also educating the patient, knowing what the plan is. So when we have patients going to MFM, we're getting their notes back. So we know they're the higher risk people. So they're giving us recommendation lists. So we know what we need to be following, how often to see the patients, what their concerns were, and everyone asking the same questions and following the same questions at each place, I think helps with continuity of care, even though it's not the same office or even the same provider seeing them every time. I think being consistent helps with the patient's peace of mind, because if they're going to one place and they tell them something and then they come to the other one, they're like, hold on, last week they told me something completely different. They're going to start questioning who's right, who's given the correct information, do we know what we're talking about, kind of thing.
Before we wrap up, I want to highlight a few important red flags for sonographers: that reversed end-diastolic flow, severely decreased amniotic fluid, a BPP score that's even 6 out of 8 that might require an NST or additional monitoring, suspected fetal abruption, fetal bradycardia, and any new major fetal anomaly. When you see something concerning, trust your training, document clearly, and communicate immediately. Ultrasound is more than just imaging. It's a clinical decision-making tool. The findings we document directly influence monitoring, referral, delivery timing, and delivery planning. And just as importantly, they help guide how we support patients through unexpected changes in their journey. This collaboration between sonographers, midwives, and physicians plays a vital role in improving outcomes for both mother and baby. Thank you so much for coming on, Rachel. I really appreciate your time.
Thank you. Thanks for having me.
Thank you so much for joining me for this episode of The Seasoned Sonographer. If you're interested in improving your OBGYN ultrasound skills and learning more about the field, make sure to subscribe to The Seasoned Sonographer on Apple Podcasts, Spotify, and YouTube. You don't want to miss any of the upcoming episodes. You can also connect with me on Facebook and Instagram at Sono Techniques Academy. Explore more educational resources on the Sono Techniques Academy app, or reach out via email, lynn@sonotechniquesacademy.com. I'd love to hear from you. If you have questions or topics you'd like for me to cover, feel free to reach out. This podcast is for you, and I want to make sure I'm covering the topics that matter most to you and to the ultrasound community. Until next time, keep striving for excellence in your scans, and I'll see you in the next episode of The Seasoned Sonographer. The information provided in this podcast and any accompanying materials is for educational and informational purposes only. It is not intended as a substitute for professional medical advice.